to Regulated and Relational, a bi-monthly podcast brought to you by the Attachment and Trauma Network. In today's episode, Tracy and Lorraine welcome Dr. Robert Anda into the studio, where they will explore the future of ACEs. Dr. Anda will be our keynote speaker at our upcoming Building Resilient Communities for Children conference. Let's join them.
Hi, everyone. Welcome back to Regulated and Relational, our podcast produced by the Attachment and Trauma Network. I'm Lorraine Schneider.
And I'm Tracy Leonard.
And we're excited to share with you from both our personal experiences and our professional knowledge what it truly means to be attachment-focused, trauma-informed, and how we can help children impacted by early childhood trauma. And today we have an amazing special guest in the studio with us, and I hope that you all have heard of the landmark Adverse Childhood Experiences Survey and the work of its principal investigator and co-founder, Dr. Robert Anda. Thank you for joining us today, Dr. Anda.
Thank you. I'm really happy to be here with you today.
Thank you. Tracy, can you tell us a little bit more about today's guest?
I would love to. So Dr. Anda is board certified in internal medicine and holds a master's degree in epidemiology. He spent 20 years conducting research as a medical officer in the U.S. Public Health Service at the Centers for Disease Control and Prevention. His research involved a variety of areas, including disease surveillance, behavioral health, mental health and disease, cardiovascular disease, and childhood determinants of health. He has more than 200 publications and received multiple awards and recognition for scientific achievements. He played the principal role in the design and publication of the Adverse Childhood Experiences Study, or the ACE study, as some of you may know it. Findings from the ACE study have been presented at congressional briefings and numerous conferences around the world. He now works as co-founder of ACE Interface to deliver training materials at the state and community level about neurobiology, epigenetics, adverse childhood experiences, resilience, and community capacity development. His dream, like so many of us, is to help create a trauma-informed nation.
Wouldn't that be wonderful?
Yes.
So Dr. Anda, let's start at the very beginning. So I'm sure we have some listeners who are unfamiliar with ACEs. So can you start with explaining what are ACEs, what was the original study, and the findings for us, and what did you get out of that?
The original study was a collaboration between the CDC and the Kaiser Health Plan in San Diego. My colleague, Vincent Folletti, met around 1990, and we found we had mutual interest. I was interested in the emotional and psychological underpinnings of health behaviors and chronic disease. And he had discovered a link between childhood sexual abuse and some of the health problems that he was working on in the preventive medicine clinic there. So we ended up collaborating on the Adverse Childhood Experiences study and surveyed about 17,000 people in the Kaiser Health Plan and asked them about what we ended up calling adverse childhood experiences. And there were 10 of those that we looked at on 3 forms of abuse: emotional, physical, and sexual abuse; 2 forms of neglect, emotional and physical neglect; and then what we called household dysfunction, that is growing up in a home where there was domestic violence that was witnessed, having mentally ill people in your home, or substance abusing people in your home, or someone incarcerated while you were growing up, and then having difficulty with your parents being separated or divorced, as relates to being around stressful relationships. So those were the 10 adverse childhood experiences, and we called them ACEs for short, the acronym ACE. And we quickly found how common those were. At the time that we did this work, it wasn't really known how common those individual adversities were, especially in a population like the one we studied at the Kaiser Health Plan, which was a mostly pretty educated, middle class, upper middle class population that had really great health care. So the ACEs were common. And then we quickly noticed that because we had looked at 10 of them, which had not been done before, that they were highly interrelated. That is, that where there was one that occurred while growing up, there was usually more than one, sometimes 2 or 3. So we added those adversities up from 0 to 10. Each one counted 1 point, and we called that the ACE score. And what was most stunning about what we found is as that score went up, the number of adversities as measured by the ACE score, a wide array of health and social problems go up in a stepwise or dose response fashion as the score goes up. And so our first publication was about how that score relates to many of the leading causes of death, that is, chronic diseases. And we were quite surprised to see how what happened in childhood, the adversity and stress of childhood, was related to adult chronic illnesses like stroke and cardiovascular disease and cancer and liver disease. So that's when we got a lot of notice about childhood adversity. I think probably what's most important at that time is it brought people who were interested in adult illness that happens later in life into being interested in what happens in childhood, if that makes sense. And so what the ACE study has done now over a number of years, more than 20 years, is it's brought interest from all sectors of society. And I know you're particularly interested in the educational system, but education, criminal justice, health, law, all now begin to understand how childhood adversity and how it tends to progress and the behavioral and health related issues that go along with it play out in all of our public systems. So it's become a gathering place for thinking about how we can do things better in this culture.
Right. I think people still have the mindset that children are resilient. And so what happened to them in early childhood doesn't affect them later in life.
Yes.
And this study proved that's not the case.
Yeah, I remember early on when I was sitting in a meeting with Dr. Bruce Perry, who you might know. I remember him saying something like, well, children are not resilient, they're vulnerable. And that's that absolutely that they're not resilient, absolutely. But I think his emphasis was that they're vulnerable to the biology of stress, and that what we've learned since the late 1990s into the 2000s, what the biology of this ACE score is about. We did when we first looked at this information, we didn't know actually how it worked, the biology of how this plays out. And so now we have some of the neuroscience from brain scans and studies of surveys linking what childhood events to differences in brain growth and development as seen on detailed brain scanning. And also now a really, really exciting field of epigenetics that tells us how our experiences can modulate the way our DNA is used, is that it doesn't cause mutations in the code. It doesn't change the code. It changes how the code is used. If that makes sense. How the reading of genes is turned on and off, kind of like a light switch. And that our life experiences can modulate how those switches are turned on and off.
Now, you mentioned, part of our passion at ATN is that education space in that childhood space. How do you feel, and do you feel that there's been progress in integrating ACEs in a school setting? And if not, like what would that look like? What could educators do to better understand those adverse childhood experiences and what it might be looking like in their classrooms?
Well, the first thing I think of when I think of education is understanding that these ACEs are very common, and that every classroom has some students in it that have experienced one or more ACEs, and maybe as much as 20 or 30% in some schools of those students have had 4 or more of them. And we know that childhood adversity can affect the ability to learn, the ability to read, how facial recognition works, how we process facial expressions, and emotional ability to regulate emotion, or simply not feeling safe in a classroom. And so all of those, being aware of how all those things play out, and be able to think of a classroom as a group of students that may have really diverse needs based upon how the adversity has affected their development. And beginning to, in broad brushstrokes, I think of moving from expecting students to meet the standardized needs that are placed on our school systems and working towards helping the schools to meet the differential needs of the students in the classroom, if that makes sense. Mm-hmm. And expecting them all to fit into a one size fits all kind of industrial model of, information in, product out. And there's very diverse needs and very diverse strengths and limitations in those classrooms. And so some of it, I believe, is just becoming more aware. And of course, when it comes to difficulty regulating behavior and emotions, students with adverse childhood experiences are more likely to have those kind of issues and to be suspended and expelled. And so one of the first things I think of is reducing or eliminating suspension and expulsion and trying to work with these children so that they can stay in a safe place and stay in school, and helping to work with them to teach them, how to regulate emotion and behavior and to take a time out or whatever it is the school can provide a safe place for them to begin to learn how to modulate their emotions and their behavior.
Right, because even as the research has shown that a home may not be a safe place. And so school might be that safe place for them, and they need it even more.
Yeah. And if we did some work in youth on probation in the state of Washington, and we saw that many of those youth on probation had multiple suspensions and expulsions during their elementary or high school years, 7 or more suspensions or expulsions. So it's also, think of it as it's a pathway into the justice system. Mm-hmm. We this country incarcerates more people per capita than any other country in the world, and we certainly don't want to do that. And if suspension and expulsion is a part of the pathway into that system, then the education system can play a role in reducing the burden of the justice system and what that places on the children and their families.
Right. Well, and you're going to be our keynote at our upcoming Building Resilient Communities for Children conference. And we believe so much in that one of the tracks we have is a youth justice track, because we need a greater understanding of those systems and what we can do to prevent children from being a part of the youth justice system, but also if they are a part of it, like what we can do so that there, is reduced rates of recidivism and, kind of to meet their needs and meet what they need in the moment.
Yeah. And that's a really important topic that we know what we also saw within the justice system on these youth in probation, that those with the higher ACE score were more likely to recommit an offense that would lead them back into the justice system again. And my colleague Laura Porter and other people in the state of Washington began to try to see is what's being delivered to the youth on probation with the highest ACE scores effective? Is it as effective as for those with the low ACE scores? And they worked to find providers or workers in that system that were good at working with the youth with the high ACE scores, if that makes sense, because not everybody is good at that. So that would be an example of fitting the needs of the youth on probation based on their score with the right form of provider or the right form of care. Right. It's again that one size fits all system, even in the probation system, needs to be modified.
Right. Yeah, absolutely.
It's interesting that you said the one size fits all, because we at ATN, we say one size fits one. That's a quote from Dr. Melissa Sadin, one size fits one.
Oh, I like that. I'm going to steal that from you and use it in my presentation.
That's great. So now that, we're coming up on almost 30 years of that original study, what's next? Like well, not really what's next. I want to get to that, but not yet. What I guess I want to say, like, if you were to, well, we never would want you to go back and redo, because we're here where we are right now because of that original study. But are there things that you would modify or change, or what would you want to explore, taking what you learned from that study?
Yeah, there's several. It's probably three big things that I think of. Is it's more about how we've learned so much, and we have a pretty good, solid, fundamental understanding of not only of what these forms of adversity are and the biology of how it works. Now, what I believe it's time. One thing I believe in is that this is something that everybody should have a basic understanding about, and that a part of my dream is that this would be a basic part of public curricula at a developmentally appropriate time with development appropriate education, so that everyone would have a basic understanding of this driver, the most fundamental driver of health and well-being that's ever been discovered in medicine and public health, that everybody understand that the kind of experiences we have shape the way we grow and develop. That's a biologic process, and that these things don't just go away.
Right.
And
Right.
I think that level of awareness would change the way that we interrelate with each other at a cultural level, at a population level. I think it would be really important, especially important for high school age teenagers or young people that are entering their reproductive years, so that they have an understanding of putting together the story of their own experiences or the experience of their parents and family, and seeing how that has shaped the pathways in their lives. And then to be able to reflect and say, this could be, are those the pathways that I wanted for myself or my family? What shaped them, and what can I do differently to shape down a different pathway that leads to healthier development and moving towards reaching a few full human potential, especially if they're going to have children.
Right.
So that they don't necessarily just pass on as what I grew up with is what I do. It could be, it's not to judge our parents, or there's no judgment in any of this, but to say, what can I do differently, and to be consciously develop that consciousness, that awareness, and being able to change so that the level of adversity and the ACE scores are lower in the next generation than they were in the prior.
Right.
And to do that one generation after another. So that's a big part of it. I think also in terms of the systems, we've talked about the education system, but that all the public systems, the taxpayer funded systems, tend to work independently. And we call that working in silos, as if what's happening outside of them isn't really happening, or being unaware of what's happening around. And to begin to get them to see how what happens in one service system influences what happens in all the others, and that to be able to look upstream in a prevention way, to say, where does the need for the service I'm providing come from, so that they can extend and begin to find ways of funding prevention activities rather than just simply providing the service, which is a treatment. Does that make sense? So I almost view our publicly funded systems as emergency rooms, so to speak, or treatment centers for the hidden adversity. right? The adversity is sort of it's real, but it's hidden in the background. So how do they look upstream, or how does my policy and practice in my particular sector influence what happens in the next one? And we just talked about education, but what about all the other ones? And is it adversely affecting what's happening in the next one, or is it making it easier in the other service systems to do what they need to do more effectively, or to prevent the need for those services in the first place? So that's sort of a systems level thinking about how adverse childhood experiences work. Um, and then I'm also concerned about the relationship between adversity and low income or low socioeconomic status.
Yeah.
And I see since World War II, the amazing disparities in health and socioeconomic status. The income divide is broadening, and we know that we're learning now what we didn't learn originally in the original ACE study, just how powerfully um, low income poverty or not growing up in enriched environments um, interacts with adverse childhood experiences to greatly inflate the need for health care and other services. It's very disproportional. Uh, Low income, along with adverse childhood experiences, that population has a much greater need for services than the rest of the population. And not only is that sad, but it's also very costly. So there's the human with the human empathy about that, but also just the dollars and the costs
Right.
that generates, both short and long term,
Right.
all the way into the Medicare population.
Yep. And those root causes, since that first study has come out, I'm sure you have seen all of the visuals and that people have created of, here's the 10 original ACEs, but here are some of those root causes, the systems, unhoused, the, socioeconomic disparities that you talked about, even to, war and refugee and environmental things that can really exacerbate
Yeah.
the ACEs.
Yeah. So
Yeah.
poverty in and of itself is not an ACE, but a lot of these ACE instances stem from that.
Where there is more poverty, there's more ACEs, and where there's more ACEs, there's more poverty. And what my own thought in that is that if we're looking at cause, the cause works in both directions, right? So where there are both, you have reinforcing causes, so to speak, and therefore that's where this greatly inflated risk of health and social problems, incarceration, poorer health, all of the things that go along with that come together. And so yeah, they're both. As an epidemiologist, we're looking for causes of why things happen the way they do, so that we can think about how to prevent the outcomes. So I think of that as we call it bicausality. So, you know,
Hey, calling all parents, caregivers, educators, child therapists, and those working in child-focused community organizations. The Building Resilient Communities for Children Conference is back. BRCC 2026 will be September 17th and 18th, and it's ATN's virtual conference that focuses on all the adults who care for, work with, and love our children. Once again, we're going to have tracks for parents and schools, youth justice, community organizations, and clinicians. Although all the sessions and recordings of all the sessions will be open to everyone who attends. There's going to be special pricing for parents and for nonprofit organizations. And yes, as always, we take purchase orders. So registration will begin in May for this September conference. Please watch our website for details. You can visit us and learn more at attachmenttraumanetwork.org/BRCC. That's attachmenttraumanetwork.org/BRCC. We'll see you in September.
We've talked, again, our focus, well, we focus a lot on the education system. You've talked about some others, but are there any fields where you think there's been more progress in integrating the ACE science? Is it a medical field? Is it education? Is it, the justice system? Are there areas that are really taking the research and, making some strong integrations with that research?
I think that I would describe it as gradual awareness building
Okay.
and gradual implementation of experimenting with what to do differently. And you may have more examples of specific schools, but I sometimes get frustrated that there isn't more of more concrete systemic examples of how this understanding has been used and is shown to reduce the need for services, or reduce certain levels of illness, or reducing things like mental health and substance abuse issues, or better school performance, the kind of metrics that we have in our systems. I haven't seen it go that far. There's maybe one instance that I can talk about that I am aware of, and it's not to say that there has not been measurable progress. But I can't follow everything. This field has become so large that I'm overwhelmed by the amount of information out there. But I think I would describe it as gradual progress. And even though the initial work was published around right before 2000, and there's much research after that, it's still relatively new.
Mm-hmm.
And I have other people remind me when I get frustrated of it takes time to change these systems. These systems that were developed, the policies and practices in the public systems were developed, if you go back, say, like 1950,
Mm-hmm.
right? And what we knew and how we thought about how things work and what was best for everyone at those points in time. And they were developed without any of this knowledge.
Right. Yep.
And so, how, the changing of policy and practice and how things are funded, those wheels turn relatively slowly. And I also don't believe that we're anywhere near critical mass of general population level understanding of this, which we talked about a few minutes ago. That my passion and my belief is that the most important thing we can do is get this information to everyone so they can think differently and do differently.
Mm-hmm.
So it's both, it's bottom up, right? It's grassroots up and top down. It's not either or, it's both.
Yes.
And so I see that as synergistic. A well-educated population interacting with a system that's trying to change policy and practice, I think, is synergistic. And an informed public will support changes in policy and vote for people that are interested in changing policies and changing the way things are funded, in a way that reduces the intergenerational transmission of adverse childhood experiences.
Yeah, because there is definitely not enough money in the prevention things that are needed here. Hardly anybody is funding prevention. And if they are, it's not nearly enough of what it needs to be. It all happens at that triage level that you talked about, thinking of it as an emergency room, where we're just triaging and treating. Yep.
And a challenge there. Number one is we can't spend our way out of this.
Nope.
Right. We can't spend our way out of what we now see. And a challenge is that the time that it takes from implementing changes and setting up system to measure whether things are changing and to seeing change is a long period of time. Right? It's not months. It's not 1 year. Generally not 2 or 3. It's a multi-year thing, and the funding of our systems is cyclic in shorter intervals.
Yes.
And so it takes courageous policymakers and politicians to begin to change the way we think about experimenting with how we do things differently, measuring, going to the expense of measuring what's done and measuring change, and doing that over a multiple years. For example, does what we do prevent adult chronic illness, which would be one thing that takes a long period of time.
Right. It takes, yeah.
Right.
Yes.
And or in thinking of the education system is what is done with young parents now, or parents to be, and the policies and practice of not only education, but policies and practice about services they receive.
Right.
How does that pay off by the time their child reaches sixth grade or kindergarten in fifth grade? So the time frames, it takes stepping back and having the courage to and patience to work on different time frames. And that's all. That's free in many fields. That's the challenge of prevention, is impatience and our historic funding cycles.
Yes. Yep.
But it's also us being proactive versus reactive.
Absolutely.
And yeah, that's important. And I think you kind of talked about this, but I don't know if you have something specific to say. What do you think the next 30 years would hold in the area of adverse child experiences? Are we going to discover more? What might that be? What should be on our radar for us to look out for?
Well, I think that I hope that in 30 years that the majority of people in this country and around the world understands how this works, how human development works, that it's a biologic process, and that the way we interact with each other and our policies and practice affect our biologic development and how we reach our fullest potential. In 30 years, that's a really great question. I do believe that we have a fundamental understanding of the neuroscience and the epigenetics. I think that is going to be fine-tuned. And to the extent that the neuroscience gets fine-tuned, it may help in the education system to be able to think, well, how does what we do work better based upon the need that's seen, right? And matching the perceived need to do something different with understanding the biology and being able to make changes that are more effective per hour spent, using human capital or fiscal resources, that it fine-tuning the biology and how the biology matches with what we see in functioning and experience might help us to do this more efficiently. And knowing when to intervene sooner.
Yeah.
Because not everybody is affected the same way by the same experiences. We all come in with our own biology and our own level of stress response, and sort of some fine tuning. And maybe I've been doing this too long, but I don't see. I think what we've established and what the neuroscientists and epigenetic researchers and other behavioral researchers have laid on this, it's a pretty strong foundation for understanding what's going on. Right now, I see the next 30 years bringing fine tuning, but maybe there will be some amazing breakthroughs in understanding that we can't even imagine right now.
Yeah. Yeah. I think just anecdotally for us at ATN at our conferences, we've seen more and more, not only interest in the neurobiology piece, but more and more presenters, wanting to present on this information. Then it's fascinating to have this understanding. And so we have, and I would agree with that completely. That is right now, that's kind of the shift in this. The people that we interact with are like, we know about ACEs. We have that background. We want more. We want the next level. And so I think a lot of that for us naturally is following what you're talking about, and is that neurobiology. And I would hope soon maybe some more of the epigenetics coming into play. as well.
Yes.
Yeah,
Yes.
I sometimes think of all this as, in some ways, just really basic. Is for even for me personally is what understanding ACEs did for me is it made me more compassionate
Yes.
Yes.
and more understanding
Mm-hmm.
and more
Yeah.
patient
Yep.
with
Mhm.
all the people around me.
Yep.
And I was at a meeting. I forgot about this. Hadn't thought about it for a long time. I was at a meeting at the Carter Center here in Atlanta, and Rosalind Carter was very much interested in mental health. And Vincent Folletti were up. We were up on a panel up on the stage at this big mental health meeting, and the former president of the American Psychiatric Association got up and said, "Why can't we just love each other better?" And I think this can help. I believe this information can help us do that.
Yeah.
I have an anecdotal experience with that. And I was at the Wind River Reservation a couple of years ago, and it was mostly in a Native American community, mostly Native American people in the audience. And I did a presentation on ACEs. And afterwards, a woman looked to be she probably about 40 years old, came up to me, and there were tears streaming down her cheeks. And she turned to me and said, "Thank you. Now I can love my mother better."
Oh.
Now I can make. I don't know what she really meant. I have an assumption that what it did is she understood her mother, who probably had experienced a lot of adversity, and because she understood her mother better, and that this is a biologic process, and that it's not her fault, and that compassion and understanding helps us love better.
That had to
Wow.
be
And that and I really believe, we can talk about science and policy and practice, but what is the power of compassion and understanding and
That is powerful.
patience? Yeah.
patience. Yeah.
And as opposed to shaming and judging
Mm-hmm.
in human life.
Yep.
Those are the most powerful forces shaping our lives. And so uh, anyway, that's that ultimately the power of this science plays out in those.
Mm-hmm.
Thank you for sharing that story.
Yeah.
That was powerful.
Yeah.
So, Dr. Anda, we understand you have a new project coming out. Can you tell us a little bit about it?
Yeah, this new project brings together some of the things we've already talked about, which is we're the research part of this is to show how in a cohort of people that we will be studying um, in young people in a Medicaid population by doing a survey of their adverse childhood experiences and things like their poverty experience and what their parents experienced, and then following over time how they move through all of the taxpayer funded systems, because there's a place in the state of Washington has the ability to link all of the information in all of the taxpayer funded systems that people encounter, all the way from pregnancy and birth outcomes all the way to chronic health care and everything in between, including the education system, and to be able to map out how the risk generated by adverse childhood experiences flows in through the system. Does that make sense? How it flows. So I was speaking with one of my colleagues this morning, and he said it's like having a new camera, right? Going from a Polaroid to a modern camera that with high definition pixels that also follows in time. This making sense? So what we have now, understanding of how ACEs play out, is snapshots, like a slideshow. Well, here's how it works out in the prison system. Here's how it works in healthcare. Here's how in each of those systems. So we will be able to. I think almost think of it like a river flowing, a river of risk that generated by adverse childhood experience, how it flows through time and space through all of the taxpayer-funded systems, and using that understanding to see how the systems interact with each other, and to create an incentive for politicians and policymakers to see this movie almost, right? Say this is a dynamic flowing river of risk, and we're not doing anything. We're not doing anything to divert the flow or stem the flow. Does that make sense? We're just treating things one at a time, which is what we talked about earlier. But to see that more vividly and to quantify how it flows, and try to pitch that to change the way the systems are funded and to fund prevention.
And this is in Washington State?
That's where we'll be working. Yeah,
Wonderful.
with the information there.
That's great.
Where that understanding will be applied, we don't know yet. We're hoping that it's part of this project is to make the case with the science and the epidemiology.
Yes. Wow.
To do this, to paint the picture. That's an example. You asked me about the next 30 years is those kind of ways of looking at this, and having a clearer view
Right.
of what's really happening out there.
Yeah. Well, and you pull in taxpayer dollars and politicians and the data, and you're going to create something that people are going to want to listen to.
But what I think what our culture does is it treats us as if we are a different person in time and space. That makes sense. So I'm a 5-year-old with a lot of adverse childhood experiences. I'm in the education system, and that presents something there, and then I show up 10 or 15 years later somewhere else, as if I'm not linked. Right? How I am as a 5th grader linked to how I am as a 19-year-old or a 20-year-old or a 40-year-old. And so it's like this snapshot. We dissect ourselves in time and space, and our systems are not continuous.
Right. Wow. That'll be fascinating to see that and to see what comes of that.
Yeah.
So we mentioned earlier you'll be our keynote at our upcoming conference. What can our attendees look forward to hearing from you? What kinds of things will you be speaking about?
Well, I'm going to do a general education about, like we've done today, what ACEs are, how they're interrelated, and how they pile up, how they add up to create more and more stress, more and more risk. Some of the biology of what that means. And then looking at just how much risk they generate, because the risks are enormous. Like how high do the risks get as the score goes up? What proportion of major health and social problems are caused by ACEs? And then maybe a quick walk through these systems that we talked about, of what we've learned about what this looks like in the education system and in the justice system and in healthcare. And the idea of creating what we call self-healing communities, where these communities understand the flow of how risk moves from one system to the next, and to make the case for the kind of changes that we've talked about today, so that the people in your audience understand that and can either work in their own systems to do that or advocate for change.
Right. And that's perfect, because, we'll have parents, clinicians, the youth justice, educators, and community members. Those are kind of our tracks, because we want to do the same thing you are, is showing that, we may all work within these, systems, but we have to work together as well, and not in those silos. And this conference is designed to do that very thing. So
that's great. Well, I'm very excited. I love having a diverse audience. I think it's so much more effective when the audience is diverse.
Yeah. Yep.
The reach is greater.
Yes. And that awareness piece that you talked about, which is so important, it continues to grow. So that's wonderful.
I have one more question for you. I read that you are an avid scuba diver.
Oh, yeah. I am. I'm,
Tell us a little
I,
more about that.
yeah, yeah. Well, I just booked a trip with my son, to go to Palau in Micronesia, going there, and we started taking these really amazing trips to places of the world like Indonesia and Philippines, and um, if I could be on a coral reef nut right now, I would prefer that to doing a podcast, actually. But I don't have. But I'm so glad that you invited me to do this.
Well, we're glad you were able to join us.
All right. Well, Dr. Anda, thank you for your time. And listeners, thank you for tuning in. And we hope to see everybody at the Building Resilient Communities for Children conference. And tune in again to our next episode. Thank you.
Great. Thank you both.
Bye.
Bye now.
And that's a wrap for today's episode of Regulated and Relational. In our next episode, Tracy and Ginger welcome Karen Mayer Cunningham into the studio. Karen will be speaking at our upcoming Building Resilient Communities for Children conference. A special thanks to Joe Kramer for donating the music. To learn more about the Attachment and Trauma Network, visit us at www.attachedtrauma.org. I'm Lauren Cassis, and as always, thank you for listening.